Hey everyone, and welcome back to part 66 of Decode Healthcare. I am absolutely thrilled to have you here today because we're jumping into an explainer on a topic that routinely trips up even the most seasoned medical coders and billers. We're going to be decoding the wonderfully complex and honestly kind of tricky world of CPT codes for normal newborn care, delivery attendance, and neonatal resuscitation. We're going to unpack exactly what you need to know to navigate the very first days of a patient's life from a billing perspective. So let's get into it.
Okay, let's dive into this. I want you to imagine you're looking at a patient chart. You have a completely normal newborn infant. The pediatrician comes in, performs the initial evaluation, and everything looks absolutely great. But then, just a few hours later, on that exact same calendar date, the infant suddenly develops severe respiratory distress and has to be rushed to the neonatal intensive care unit. How do you code that? Who bills what? Do you just lose that normal care code? Well, we are going to map out this exact chronological journey and solve this clinical scenario together.
Here's our agenda for today's explainer. We'll start with normal newborn care basics, then move to code selection mechanics, normal versus sick conversions, delivery attendance and resuscitation, and finally, we'll wrap up with the top audit red flags. Understanding these baseline rules is absolutely critical before we start tackling the exceptions and audit traps. All right, Section 1, Normal Newborn Care Basics. Before we even look at a single code, we have to establish what actually qualifies as a normal newborn in the coding world. So what does normal mean here? Well, it refers specifically to the evaluation and management of infants who are successfully transitioning to extrauterine life without any significant acute distress. This applies to the initial care of the newborn in those first few days after birth, right before they are discharged to go home. And keep this in mind, the CPT manual strictly defines a neonate, or newborn, as an infant from birth through 28 days of age. If they suddenly require specialized interventions, they just don't fit this baseline category anymore. Now, what's really interesting about this is the vast scope of what these codes actually cover. The normal newborn codes, which range from 99460 to 99463, are per dime global codes. That means they bundle together a whole lot of work for that single day. They include taking the maternal and fetal history, doing the newborn physical exams, ordering basic diagnostic tests, having meetings with the family, the whole shebang. You absolutely cannot unbundle routine exams or family meetings to bill them separately because these per dime codes already cover the entire day's normal E&M services. Moving on to Section 2, Code Selection Mechanics. Now that we know what's included, how do we choose the exact right code? It really boils down to the setting and the timing of the baby's discharge. Let's break down how location and timeline dictate your code choice. First up, CPT 99460. You're going to use this for the initial care per day for a normal newborn infant in a hospital or birthing center. But what if the baby was born at home and evaluated there? That's when you drop down to 99461. This is for initial care in settings other than a hospital or birthing center. And for the following days of a normal hospital stay, you'll use 99462, which covers subsequent hospital care. But I really need you to pay close attention to this specific code, 99463. This one is a massive trap for billing departments. 99463 is strictly for the initial hospital or birthing center care when the normal newborn is admitted and discharged on the exact same calendar date. You can't just use the standard initial code, 99460, if that baby goes home the very same day. If admission and discharge happen on the same date, 99463 is your one and only choice. Section 3, Normal versus Sick Conversions. This is where we pivot and finally answer our opening question. What happens when our perfectly healthy, normal newborn suddenly develops a complication? So, the crucial point is understanding your diagnostic pairing rules. On the normal side of things, your codes 99460 through 99463 are strictly paired with the Z38 series of live-born ICD-10 codes. But if that infant develops an acute complication, maybe it's respiratory distress, hypoglycemia, or neonatal jaundice that requires phototherapy, you have to abandon the normal newborn pathway. You transition right over to the sick newborn pathway. Because acute complications are now driving the medical decision-making, this means using standard inpatient EAM codes like 99221 through 99239, or stepping up to initial intensive care, like CPT 99477, paired with the specific ICD-10 codes for those acute conditions. And here is the golden rule straight from the CPT manual for that day one crisis we talked about earlier. If a newborn receives normal newborn care, say code 99460, and later on that exact same day they become critically ill, the same individual provider can capture both services. You would report the initial critical care code, like 99468, but you must append modifier 25 to it, in addition to the normal newborn code. This shows that a significant, separately identifiable service happened on the same day. All right, Section 4, Delivery, Attendance, and Resuscitation. Let's rewind the clock a little bit and step into the delivery room to talk about the specialized codes used before the baby even makes it to the nursery. Take a look at these official CPT guidelines detailing delivery and birthing room attendance and resuscitation services. These rules are extremely explicit because, let's face it, we have multiple providers in the room during delivery, and the payer needs to know exactly what role each person played. We're primarily dealing with two codes here. CPT 99464 is for simple attendance at the delivery and the initial stabilization of the newborn. Basically, you're on standby to make sure the baby transitions safely. Contrast that with CPT 99465. This code is for active delivery room resuscitation. To bill 99465, the provider has to be actively providing positive pressure ventilation, chest compressions, or both, in the presence of inadequate ventilation or cardiac output. Now, if you want to co-build these delivery room codes correctly, you have to follow these steps. Step 1, the attendance must be specifically requested by the delivering physician, usually the OBGYN. Step 2, you can never ever report 99464 and 99465 together for the same encounter. If you attend the delivery and end up performing resuscitation, the resuscitation code subsumes the attendance code. In Step 3, if you do the delivery room resuscitation, and then you also perform the normal initial newborn care later that day, you can co-build them, but you must append modifier 25 to the appropriate EM code. And this brilliantly illustrates how procedure billing layers right on top of E&M billing. While you can't double bill those attendance codes, you absolutely can and should bill for distinct, necessary procedures performed during that resuscitation. For example, if you have to perform an endotracheal intubation, you report code 31500 separately, in addition to the 99465 resuscitation code. Just make sure your documentation clearly shows it was a necessary component of saving the baby's life. Finally, Section 5, Top Audit Red Flags. We are now turning our focus straight to the biller's desk to make sure we're protecting your facility's hard-earned revenue. Okay, here's a rapid-fire list of the absolute easiest ways to fail an audit and lose reimbursement. Number 1, reporting 99460 for a baby admitted and discharged on the same day instead of the required 99463. Number 2, double billing delivery attendance and resuscitation for the exact same encounter without proper modifier use or clinical documentation. And number 3, unbundling routine initial exams or family meetings that are already globally included in your normal newborn care per diem codes. So I want you to ask yourself this. Looking at your own facility's billing habits, will your claims survive an audit if you unbundle these newborn procedures, or did you just trigger a massive red flag for the payer? Understanding the global per diem rules is literally the only way to ensure your claims make it through cleanly. Mastering these concepts doesn't just protect your revenue and prevent audits. It ensures that the patient's medical record accurately represents their unique clinical journey from the very moment they enter the world. It's a lot to keep track of, but getting it right is crucial. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.